very good morning to dear colleagues and members of Pathoindia community. We are going to begin with an innovative online non-live teaching sessions on the occasion of Silver Jubilee year of Pathoindia, and I am very honored to be a part of Pathoindia community and will be convening the session on lung pathology. At the outset, I would like to thank Dr. Johnson, Dr. Neha, and Dr. Arpan for giving me this opportunity of being a moderator and convener of this session. And let's jump straight on to the topic which I'm going to cover today, which is decoding lung lesions, a pattern-based approach. So, whenever we get a biopsy from a sample from a patient with diffuse lung infiltrate, it is intimidating for a pathologist. Pathology is referred to as interstitial lung disease and is nearly always the result of diffuse parenchymal injury. Unfortunately, there are many ways to injure the lung, and tissue response depends upon the nature of the injury combined with its acuity, severity, and duration. To make matters worse, histopathology is highly dependent on when the lung biopsy is performed, relating to the onset of a given injury. Additionally, more than one episode of injury and little or no clinical imaging information. It leads to even more confusion, and even the most experienced histopathologist is in a fix. So before jumping on to the histopathological patterns, let's just go through the clinical patterns as well as the radiological patterns, because no diagnosis can be made in a small lung biopsy without clinical and imaging correlation. Clinically, the patient can be in acute presentation, subacute or chronic, which is spanning many months to years. Acute, mainly dealing with infection, diffuse alveolar damage, acute eosinophilic leukemia, and acute injury related to drugs and so on. Subacute, the prototype is hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis. And chronic is related mainly to rheumatic disease, autoimmune disorders, drugs, pneumoconiosis, and smoking related diseases. Coming on to the radiological patterns of diffuse lung diseases, HRCT provides key information that is useful to the histopathologist with a lung biopsy specimen in hand. In lung biopsy, four basic patterns of radiological disease can be seen: increased attenuation, reticulation with parenchymal distortion leading to seen in cases of fibrosis. There can be nodules as well as mosaic patterns. So we now go over to the histopathological patterns which we commonly encounter in a biopsy of interstitial lung disease. So there are different patterns, pattern 1 to 6. Pattern 1 is namely acute lung injury, pattern 2 fibrosis, pattern 3 chronic cellular infiltrates, pattern 4 alveolar filling pattern, pattern 5 we see nodules, and pattern 6 is minimal change or nearly normal lung biopsy. So let's cover these one by one. Pattern 1 is acute lung injury. So when you see a case of acute lung injury, basic elements include interstitial edema, intraalveolar fibrin, and reactive type 2 pneumocyte cells. Fibrin points to the acute lung injury, and there are certain key modifiers which can be seen in the histopathology, like hyaline membranes, tissue necrosis, eosinophils and fibrin in alveoli, hemocentrin-laden macrophages, background fibrosis, which is like acute and chronic disease. So depending upon these modifiers, their further pattern 1 is further divided into 1A, 1B, 1C, 1D. And acute lung injury is the histopathological pattern which is associated with it. Onset is acute, like hours, days, or weeks. And there are several different types of acute lung injury, like diffuse alveolar damage, acute eosinophilic pneumonia, and so on and so forth. When specific findings are incomplete, when there is no hyaline membrane, the generic term acute lung injury is appropriate for the pathologist to say. So this is the scanning power of an acute lung injury, which gives a lot of eosinophilic appearance, mainly due to fibrin and edema. Coming on to the 1A pattern, which is basically with hyaline membranes or diffuse alveolar damage. So this arrow is pointing towards the hyaline membrane. And also in this case, along with some organizing pneumonia-like features. When the membranes are present, we can very easily give the term diffuse alveolar damage. And it is a common histopathological pattern of injury in acute diffuse lung disease, particularly in patients with clinical ARDS and immune suppressed patients. As the name implies, it's a diffuse process, but is not always uniform in severity or appearance from one microscopic field to another microscopic field. There are various conditions associated with diffuse alveolar disease like infections, toxic inhalants, drug reactions, shock, and so on and so forth. Second pattern which we commonly encounter is acute lung injury with necrosis. And necrosis, whenever the necrosis is seen, the differential diagnosis comes into picture is infection, most commonly tuberculosis in Indian setting, then infarction, neoplasm, and Wagner's granulomatosis. Special stains for organisms like Z-Nielsen staining acid-fast bacilli required for all lung specimens that show acute injury. So whenever we see necrosis, it's also a pattern seen in acute lung injury. And the next pattern is 1C pattern with alveolar eosinophils. Now, eosinophils are also a common presentation in acute lung injury, and the different causes of eosinophilic lung disease as include infections, asthma, Churg-Strauss syndrome, and various drug reactions. So this is a lung biopsy, and on the high PAL, you can appreciate a lot of eosinophils in this. 1D pattern includes acute lung injury with diffuse alveolar hemorrhage. So there is evidence of recent as well as remote hemorrhage in the form of hemosiderin-laden macrophages. So this is important, and this is the most important feature for distinguishing the immunologically mediated hemorrhagic syndromes from other forms of acute lung injury. In more chronic cases, this dense macrophages may even mimic the other entity, which is idiopathic interstitial pneumonia, referred to as desquamative interstitial pneumonia, which we'll cover. Organizing pneumonia is common in this setting and often associated with fibrin in the alveoli. Fibrin is pointing towards the acute nature, as alveolar fibrin is not an expected finding in idiopathic desquamative interstitial pneumonias. So here we encounter a lot of hemorrhage. This is the high power of showing hemosiderin-laden macrophages. And there are different causes of diffuse alveolar hemorrhage ranging from immunologically mediated like Goodpasture, vasculititis, Wegener's granulomatosis to others leading to pulmonary veno-occlusive diseases. Now there is a finding like capillaritis. The presence of capillaritis is one of the few medical emergencies in pulmonary pathology. It is distinctive, but it can be quite focal, and there are neutrophils again within the alveolar wall, and they do not go in the lumen, along with a lot of hemorrhage. So this is a case of capillaritis in diffuse alveolar hemorrhage. The 1E pattern is acute and chronic disease like acute lung injury with background fibrosis. So it can occur as a natural escalation of an underlying chronic lung disease, or community acquired pneumonia may also be superimposed on stable chronic lung disease. So we're done with pattern 1, which was acute lung injury. Coming to the pattern 2, which is fibrosis, it will cover all the important topics like UIP, NSIP. So if further, basically what do you expect in pattern 2? There has to be dense collagen deposition in the lung parenchyma, accompanied with some degree of structural remodeling with alveolar loss. The key modifiers include with temporal heterogeneity, which is seen in UIP, which I'll cover now, with uniform alveolar wall fibrosis seen in NSIP. It can be fibrosis with airway-centered scarring, with isolated stellate scars, and with microscopic honeycombing only with pleuritis. So these are the common sub-patterns of pattern 2 fibrosis. Before going to the sub-patterns, there is something known as honeycombing. So this is the gross photo of a lung showing multiple cysts filled with fluid. This is known as honeycombing, commonly seen in end-stage lung disease. So these are often preceded by honeycombing, which are cysts seen at the microscopic level. So these are the honeycombing remodeling, which is seen in the cases of late fibrosis. So any end-stage lung disease is going to show fibrosis with honeycombing, and this is a lung biopsy. You can see these anthracotic pigment, and these are the cysts which are being seen in the low power. So what is the sub-pattern? The sub-pattern is fibrosis with temporal heterogeneity. UIP is the prototype of this entity, standing for usual interstitial pneumonia, and there is a temporal heterogeneity. What does that mean? That there are zones of normal lung tissue adjacent to the zones of advanced architectural remodeling. So there is a normal zone along with a certain zone of lung which is showing fibrosis. So initially there is a subpleural fibrosis, which later on it becomes more advanced, and there is a lot of fibrosis with centrilobular sparing. and honeycombing. These are the small cysts which are lined by columnar epithelium and show neutrophils and mucus. This is especially an early feature of these UIP cases. Then there is a fibroblastic foci, something known as fibroblastic foci, in which there are immature fibroblasts and they appear to be just adjacent to a normal lung parenchyma. So they are interface between the dense scar and an adjacent normal lung, and these are seen commonly in UIP cases. Coming to the next pattern, which is 2B, fibrosis with uniform alveolar wall involvement. It involves interstitial fibrosis that tends to preserve the alveolar structure. So there is uniform alveolar wall involvement or alveolar wall fibrosis, commonly seen in fairly limited group of ILDs like rheumatic disease, chronic drug reactions, and some examples of chronic hypersensitivity. So it was, as I told you, it is now referred to as NSIP. It was formally described by Katzenstein on 64 patients of lung biopsy specimens, and it was the term that was coined by them. There is another cellular form of NSIP which I'll discuss later, but to start off with, this is the fibrotic form of NSIP. So why go to such pains and take pains and distinguish between UIP and NSIP? Let it be a one single entity. No, that cannot be done by because UIP has a rapid downhill course while NSIP has a much better prognosis and it responds to steroid therapy while UIP does not respond so well to the immunosuppressive therapy. So the need arises for a pathologist to arrive at a conclusion that is it favoring UIP or NSIP. Coming to subpattern 2C, which is fibrosis with the airway center distribution. In this, you can appreciate a bronchiole, and the fibrosis is centered around the bronchiole. So it is mainly seen in inhalational agents which are causing the fibrosis. Like example, hypersensitivity pneumonitis, aspiration associated injury, even in rheumatic or immune mediated systemic conditions and idiopathic in majority of the cases. So there is an airway centered fibrosis which is characteristically seen in this pattern. 2D includes fibrosis with isolated stellate scars. Mostly, this is a star-shaped scarring seen in the lung parenchyma, and they are mainly seen in late stages of smoking-related lung disease. They may be incidental, like when the biopsy is performed for localized disease such as carcinoma, and we have to report it as smoking-related interstitial lung disease in the setting of ILD as the correct diagnosis if we see a stellate scar fibrosis. 2E is a relatively uncommon fibrosis with microscopic honeycombing only. So many unrelated lung diseases can result in end-stage remodeling of the lung with microscopic honeycombing cysts. So to arrive at a diagnosis, clinical context is essential. For example, if honeycombing is seen in a 60-year-old patient and there is peripheral bibasilar fibrosis in HRCT, the correct diagnosis is going to be cryptogenic fibrosing alveolitis. So in this setting, the pathologist should use only the descriptive term, which is advanced microscopic honeycomb remodeling only, because UIP also requires some form of preserved normal lung in the biopsy to establish temporal heterogeneity. So in case you see only the honeycombing, you have to keep guard that it may not be UIP, but some other entities as well. 2F is fibrosis with pleuritis when the lung biopsy sample shows fibrosis and the pleura is also involved, commonly seen in cases of rheumatic diseases. So we're done with pattern 1 and pattern 2. Pattern 3 is mainly chronic inflammatory cellular infiltrates, chronic inflammation mainly comprising of lymphocytes, plasma cells as well as macrophages. So as the name suggests, there has to be chronic inflammatory cells within the alveolar walls. And the key modifiers are, it may be with pure cellular interstitial pneumonia, poorly formed granulomas, well-formed granulomas, diffuse alveolar wall fibrosis like pattern 2B, and confluent dense fibrosis like pattern 2A UIP pattern. So let's cover all these one by one. Now, it is a very common pattern seen among ILDs, and it is not very helpful in arriving at a specific diagnosis. We tend to see a lot of lymphocytes, plasma cells. We then start looking for granulomas. Are there any granulomas? There are macrophages. So the biopsy appears more blue in contrast to the acute lung injury, when there's fibrin, and the biopsy appears more pink on the scanning magnification. So the subpattern 3A, cellular infiltrate with pure cellular interstitial pneumonia seen with lymphocytes and plasma cells. This entity includes pure cellular form of NSIP, which is very rare. There is no fibrosis, and the cellular infiltrates are seen in the interstitium. Small, you can see poorly formed granulomas, then the diagnosis shifts towards the hypersensitivity pneumonitis. 3B includes pattern with poorly formed granulomas, and as I said, hypersensitivity pneumonitis is the prototype of this, also known as extrinsic allergic alveolitis, and it's commonly seen nowadays because of a lot of allergies being diagnosed. HRCT findings include ill-defined centrilobular nodules in the mid and the upper lung zones. Cellular interstitial pneumonia with well-formed granulomas. When we see well-formed granulomas, we are going to think in the direction of infection, but don't forget sarcoidosis also as one of the differential diagnoses, though it appears more in the nodule form than in the interstitial pneumonia form. Still, sarcoidosis comes in the differential diagnosis along with infections and aspiration pneumonias if granulomas are present in the alveoli or the alveolar ducts. So we had covered pattern 1, pattern 2 and pattern 3, which is half of the patterns. Let's go on to the next pattern, which is pattern 4, and which was alveolar filling lesions. Now alveoli are being filled by either cells or some other material which is non-cellular. So depending upon what material is filling the alveoli, there are different sub-patterns. Like with immature fibroblasts, it includes organizing infections, more commonly nowadays called as cryptogenic organizing pneumonias. Then if the macrophages are present, you shift towards DIP, RBI, ILDs. With proteinaceous material, the differential diagnosis becomes pulmonary alveolar proteinosis. If the alveoli are filled with blood, then pulmonary hemorrhage comes into the picture. And with neutrophils, it's mostly seen in autopsies of bronchopneumonias when the neutrophils are filling the alveolar lumen. So this is the alveolar filling, diffuse alveolar hemorrhage along with alveolar filling. The first 4A subpattern is OP, organizing pneumonia pattern, in which there is organizing plump fibroblast and immature connective tissue within the alveolar ducts. So it is known as, initially it was known as WOOP, but now more commonly it is known as COOP, which is cryptogenic organizing pneumonias. The patient present in acute or subacute clinically, and the most consistent finding is patchy involvement of the air spaces by small tufts of immature fibroblasts, which are known as Mason bodies and which are distributed within terminal bronchioles. Other findings can include inflammation, which is chronic fibrin, prominent type 2 pneumocytes, and foam cells in the air spaces. So there's patchy involvement of air spaces by these fibroblastic foci, and that leads to the alveolar filling pattern with immature fibroblasts. Number of entities in this pattern is seen: organizing infection, hypersensitivity, pneumonitis. So it's not a specific entity, can be seen in multiple conditions. 4B pattern, when the macrophages are seen in the alveolar lumen, and then the picture comes into again many entities like obstructive pneumonias, exogenous lipoid pneumonias, infections, histiocytic pneumonias, respiratory bronchiolitis associated interstitial lung disease, desquamative interstitial pneumonias. So all these come into the differential diagnosis, and then these are the large vacuoles of lipoid pneumonia which are seen along with associated fibrosis. So this is alveolar filling with macrophages. Or see, when the alveoli are filled with this homogeneous granular eosinophilic material with a retraction artifact at the periphery, and you can even appreciate some cholesterol clefts and hyaline globules. So the prototype of this pattern is pulmonary alveolar proteinosis. Occurs commonly as idiopathic, but may also occur as secondary phenomena in occupational diseases, especially dust-related, drug-induced injuries, hematological diseases, and settings of immunodeficiency. Also differentiated from pulmonary edema and pneumocystis, the granularity of the alveolar material is the one which clinches the diagnosis. 4D, when a lot of blood and citrophages are seen, and it is a alveolar hemorrhage syndromes under pattern 1D are the diagnosis of exclusion. Sometimes striking alveolar hemorrhage can be seen in urgent lobectomy specimens from patients with persistent hemoptysis related to bronchiectasis or other airway abnormality. So the clinical context is essential, as this is also most often a localized phenomena rather than a diffuse phenomena in which the blood and citrophages, both remote and recent hemorrhage is seen. Pori, when neutrophils are filling the alveolar lumen, and acute infectious bronchopneumonia is a prototype commonly seen in autopsy material. And when it is seen very focally, the differential diagnosis includes capillaritis and diffuse alveolar hemorrhage. We're done with pattern 4. Pattern 5 is nodule. It is easily discernible at low scanning magnification, and the basic elements include nodules, which can be a single nodule or a multiple nodule, small nodule or a large nodule, or a well nodule or a poorly formed nodule. So, key modifiers include these nodules can be composed of lymphoid cells and interstitial lung disease. Nodules can be of atypical cells, maybe malignancies, which we are not going to cover in this lecture. They can be well-formed granulomas on higher magnification, most commonly tuberculosis in an Indian setting, with macrophages and dust in silicosis. Even nodular LCH can present as a nodule, as it shows Langerhans cells and stellate scars on these nodules, and with organizing pneumonia-like picture. So we're going to just cover up the three these nodules. They are seen. This is a case of sarcoidosis in which multiple numerous nodules are seen. So the nodule pattern can be either with granulomas or with macrophages and dust, or with Langerhans cells and stellate scars. And the granulomas can also have a multiple etiologies, like most commonly infections, then sarcoidosis, rheumatoid nodules, pneumoconiosis, aspiration pneumonia, and so on. Again, these are sarcoid granulomas surrounded by a dense collagen which is brightly eosinophilic. And this is a case of silicosis, again showing nodular appearance on the lung biopsy. Then there's a LCH nodule or nodular LCH showing these histiocytes which are Langerhans positive along with eosinophils, which clinches the diagnosis. Then coming to the pattern 6, in which we see a nearly normal lung biopsy on the scanning magnification, the findings are really not in concordance with what the patient is experiencing or patient is presenting with. So it's pattern 6, which is minimal changes, but we have to go on the high power. So the basic element includes little evident pathology at a scanning magnification. However, on high power, we can come across constrictive bronchiolitis, vascular or lymphatic pathology, or even cyst can be observed. So in changes in constrictive bronchiolitis is near normal, quite subtle. You cannot see anything abnormal. Oh, it's a normal biopsy. But this patient was a case of constrictive bronchiolitis and severely hypoxic. So this is not going in concordance with what the patient is showing. So on high magnification, this is a pulmonary artery bifurcation, and this is a bronchiole, and the lumen is obstructed or decreased along with surrounding these bronchioles is a lot of fibrosis, muscle hypertrophy can be seen, mild chronic inflammation, and scarring can be seen. These are the findings which are in concordance with minimal changes with constrictive bronchiolitis. Even the vascular or lymphatic pathologies can be discerned at high power, which this is example of flexiform lesion of pulmonary hypertension. And it is composed of a pulmonary artery, and even in the low power, you can in the lower area you can see a glomeruloid structure. Then with cysts are observed in lymphangioliomyomatosis, which are easily seen on high power and appears as nodules on the low power. So do the patterns occur independent of each other, or they can occur together? Usually we find 2 or 3 patterns together. So some overlap is there to occur. For example, some infections, they are both nodular as well as they have airspace filling lesions, whereas others are characterized by acute lung injury and diffuse airspace filling, like in pneumocystis and pneumococcal pneumonias. So some diffuse inflammatory lesions, all the 6 patterns may be present, as in some cases of rheumatoid lung. So what do we do in these cases? Recognizing the dominant pattern is essential in addressing the primary clinical concern. So the patterns are going to overlap. You have to recognize the dominant pattern to come at a conclusive diagnosis and help the clinician. A word about transbronchial biopsies. Transbronchial biopsies are also fairly common, and the pattern-based approach works also for the limited samples which are obtained by transbronchial biopsy. For example, you can even see acute injuries, cellular infiltrates, granulomas, vascular diseases, alveolar filling processes. All these can also be observed on the transbronchial biopsies, though it's a limited biopsy. However, fibrosis is difficult to discern on transbronchial biopsy. That is a pattern that should not be diagnosed on a transbronchial biopsies. So to summarize, We learned about pattern 1, which was acute lung injury with hyaline membranes. Most important is diffuse alveolar damage. Then with necrosis, eosinophils, diffuse alveolar hemorrhage, and with background fibrosis, which is acute and chronic lesion. Pattern 2 includes fibrosis, which includes the temporal heterogeneity or uniform alveolar wall involvement, respectively known as UIP and NSIP. Then there can be airway centric fibrosis, isolated stellate scars with microscopic honeycombing only, or with pleuritis. Pattern 3 involves chronic inflammatory infiltrates in which there is pure cellular interstitial pneumonias, most commonly the cellular form of NSIP. They can be granulomas, poorly formed or well-defined granulomas. Pattern 4 involves alveolar filling pattern, which can be filled with immature fibroblasts, macrophages, eosinophilic material, citrophages, and neutrophils. Pattern 5 is nodular with granulomas, silicosis, or even LCH. And the pattern 6 is minimal changes, which are very subtle, including the cystic changes as well as the arterial changes. So the reference include Leslie. I hope I have been able to clear some of the patterns which are commonly seen and encountered in the lung biopsies. However, the house is open for discussion. You can post your doubts, your queries, and even the slides, photographs to come at a consensus diagnosis. And this is a very good book by Leslie, and which is dealing with the pattern recognition series in pulmonary pathologies, and support edition is available on 2023. So if you have the opportunity to go through this book, you'll never be confused with what is the pattern. So let's just wind up this session, and we'll get in touch with you through email to have any questions, any doubts. You're most welcome. Thank you so much.